Okay. All right. Well, welcome everybody. My name is Davis Moline. I'm on the education committee for AOC PM&R. So thanks for coming out tonight. And we're all, I know, super excited to hear from Dr. Clay Smither. So I'll just do a little bit of an intro. And then something that is new this year, I think, for AOC PM&R is they're having a club sponsor. And actually tonight it's the school that I attend, so Liberty University. College of Osteopathic Medicine in Lynchburg, Virginia. So thankful for them for sponsoring tonight's event. And it's a beautiful place out in the Blue Ridge Mountains. So if you ever get a chance to visit in Central Virginia, come out. They don't have a Trader Joe's, but that's okay. We have other things, but so I'll just introduce Dr. Smither here. So Dr. Clay Smither is a consultant in the Department of Physical Medicine and Rehabilitation at Mayo Clinic in Rochester, Minnesota, and is an assistant professor in Mayo Clinic, the Mayo Clinic College of Medicine. He completed his physiatry residency at Mayo Clinic in 2019 and an amputee rehabilitation fellowship at the Central Virginia Veterans Affairs Hospital in 2020, which I believe is in Richmond, here in Virginia.
Exactly.
Yeah. His leadership roles include Associate Program Director for the PM&R Residency and Medical Rehabilitation Division Chair. And his clinical interests include amputee rehabilitation, osseointegration, brachial plexus disorders with amputation, and advanced gait training with reduction in falls. So very thankful and very excited to have Dr. Smither here. And the floor is yours, Dr. Smither. Go ahead.
Sweet. And I think there's like a bunch of people in the waiting room too. Can let them in. So looks like we got pretty nice turnout. Good to meet everybody. I'm just going to chat for like 45 minutes. And then I'll pause for kind of questions. If something like totally doesn't make sense, you can throw it in the chat, whether or not I'll see it. I'm sure Davis will keep an eye on things too. So yeah, I'm just going to kind of overview what I do in amputee rehab, hit a few concepts. I see a couple familiar names here, so apologize if some people have heard this before, but it should be a good time. I love my job. I feel extremely lucky to do what I get to do. So big picture, um, what I do here in PM&R is amputee rehab, and we've got an integrated PM&R clinic with our with our teams here. So anytime someone's at risk of potentially needing an amputation surgery, we get a referral and we'll have conversations with people, if possible, in the clinic setting before going through this. So a lot of what I do is meeting folks, hearing their stories, and then helping them kind of get through a really, really tough time. So the first time I walk in and meet somebody, they're usually in a pretty tough place, and there's a lot of unknowns. Um, and I try to take some time and be with them at that time, give them some education, and then I'm very blessed with my job. I get to kind of walk with them through the ups and downs. I will, our team, so not just me, but Dr. Andrews as well, gets consulted when people then get admitted in the hospital, and then we follow them in the outpatient setting. So we kind of are along with them during each of these steps when they're going through a really difficult time. So that's just big picture of kind of my day-to-day life. Like I said, it's clinic, it's hospital, it's a lot of logistics and figuring out follow-up for these folks and making sure they get the rehab and the training and the componentry that's really going to set them up for success. So let me attempt to share my screen here. I'll make that go away, and I'll make that go away. Do that now. The magic happens when I go big screen. And I may need to flip it. My goal is for you to see the slide without the notes. Have I achieved my goal, Davis? I got a thumbs up. All right, sweet. So we'll kind of go through some 101 things and then just chat. And we will see if I make it through all my slides. I may meander down little bunny trails, so I apologize ahead of time. But what I want to touch on briefly is we'll talk about both lower limb and upper limb amputation. We'll talk about some post-operative interventions, and we'll talk a little bit on componentry. I'm not going to do a crazy deep dive in the time frame we have, but just give you a little bit of taste of what amputee rehab is like from a PM&R standpoint. I might grab that. All right, let's see how I do with this. So I'll start with a case study. This did come from my fellowship year, so I was very blessed to work at the VA in Richmond, Virginia during my fellowship year, and absolutely loved it. Loved working with that population. Just super cool people. So I had a patient there, and he was 68 years old, and he had all of the medical things, diabetes. He was on dialysis. He actually had a dialysis machine at home where he received that. Unfortunately, he had peripheral arterial disease as well. He had had some toe amputations, and then had worsening gangrene and went with a transmetatarsal, which is a midfoot amputation surgery. He was in the hospital. It wasn't healing. He had an infection, and I was consulted along with the surgery team and the wound team to talk about possible surgical and rehab options. So that's a pretty common story. Patients who lose limbs due to chronic disease often have multiple diseases. And as a result, their functional status has taken a toll. So what else do we need to know? Well, we're good rehab doctors, so we want to know their functional status, kind of get an understanding of what they're doing on a day-to-day basis. So he lived his life. It was an old split level home, but he had stair glides at like every level, which was nice. He didn't really get outside the home very much, to be honest. He had quite a bit of adaptive equipment there with him, cane, walker, and wheelchair. And so taking a step back, thinking about this patient population, there are a lot of amputations yearly, estimated 185,000 per year in the United States. There's also a different population with our conflicts overseas where there were 1,600 major amputations between '01 and 2014 of service members. When we think of the civilian population, though, it is very largely the amputation due to either vascular disease or diabetes or both. And so, again, these folks have a lot of chronic disease that has affected them and affected their functionality. The next most common is 16% due to trauma, and then we have cancer and congenital limb difference. We see more cancer amputations here at Mayo just because of our surgical practice. We've got orthopedic surgeons that specialize in cancer treatments and surgeries, so we tend to see a little bit more here at Mayo. It's also important to understand what this means on a larger scope. So folks that get an amputation due to this vascular disease, some studies have shown a less than 50% 5-year survival. So, like I said, a lot of these patients are very chronically ill, and unfortunately, they're not going to be with us as long as they might want. There's also a 50% chance of a second amputation in 5 years, the contralateral limb. So, if one foot is at risk, the other one is as well. So, we kind of look at both feet. In '05 was estimated to be just over 1.5 million people with limb loss. We're expecting this to go over 3 million by 2050. There's been a recent study that even postulated more than that. So there's a lot of people in the United States living with major limb loss. So it's a very common pathology, unfortunately. So when we're looking at things and we think about level of amputation for a patient, there's a lot of different things to think about. We want to think of healing potential. So it's best if you can have one surgery and heal from that and not require further surgeries. Blood flow is absolutely critical for that incision in those tissues to heal. We also then need to think about what's going to be their function with a prosthesis and kind of helping them cast a little bit of vision and understanding of once they're healed, what could that function actually look like? So this is just a brief overview of arterial studies. And so we get these very commonly on our patients in the hospital who are facing possible amputation. And what I want you to do is kind of look at this picture here, and that shows you what's going on inside the artery. So diabetics typically can get a lot of calcifications in their arteries. In this example, their artery is wide open, but the walls are calcified. ABI is an ankle brachial index. So you get a blood pressure at the ankle, and then you get a blood pressure at the arm, and you look at the ratio. For this one, it's going to be over 1.4 ratio because you're not able, the vessel at the ankle is so calcified you can't compress it with the blood pressure cuff. So you get an artificially elevated ABI. A normal ABI is kind of this 0.9 to 1.4, and then it drops from there. Basically, the blood pressure at the ankle just drops lower and lower as this lumen kind of closes. And then when you throw the Doppler on, this is what it looks like. So we want to see a nice big triphasic wave that reflects the contractility of the heart. This goes to biphasic, which is not as responsive. And then when you get all the way down to monophasic, this is just a trickle of blood flow here. So even as a physiatrist, I'm not a vascular surgeon. I'm not performing interventions, but it's important for me to review this, to think about healing potential, and then talk to the patients and help them understand their potential and their goals. So we look at those things. We also look at oxygen. So they put little sensors on the skin and see what those oxygen numbers look like. What we want to see is above 40 with the TCPO2s. If it's below 20, it's very unlikely to heal. If it's 20 to 40, it's kind of in that gray zone borderline. So you kind of look at the waveform, you look at the ABI, you look at the oxygen saturation at the skin, and all those things help the surgeons kind of determine what level is going to be optimal to heal. Certainly from a functional standpoint, the more distal the amputation, the easier it is going to be to use a prosthesis. So we think about amputation surgery. Sometimes they need to do a stage surgery if it is an emergent, and so they have a guillotine amputation. If, in particular, if you've got a life endangering infection where you need to really just remove that infected limb and then go back and revise and close. You can also do a single stage surgery. Myodesis is a procedure where the muscle and tendon is sutured to the bone, and a lot of our surgeons do that here, which makes for a really nicely formed limb that has good muscle control. I apologize if I'm talking too fast, so somebody yell at me if I say something that doesn't make any sense here as I roll through. Here are all the different major lower limb levels from transtibial, also known as below knee amputation. You can do a knee disarticulation, transfemoral, which is above knee, hip dysartic, hemipelvectomy. We actually do fit people with hemipelvectomy amputations. So it is quite a challenging fit. It is a challenging prosthesis to use, but we do successfully do that multiple times per year. It's actually a somewhat common surgery here. It's a pretty aggressive surgery, life sparing. Usually people getting these types of surgeries, the hemipelvectomies, is due to cancer. So you get a large sarcoma in the pelvis that needs to be removed to save the patient's life. So we do, like I said, I do a lot of counseling. I'm sitting down with a patient, I'm talking to them about their functional outcome. So I talk about waking up after the surgery. You may feel like that leg is still there. You may feel that pain's still in the leg. So kind of advising them on phantom pain so that it doesn't completely take them by surprise. This here that this patient has is a rigid non-removal dressing. We've actually added a pylon and a foot. Now it's only touch toe weight bearing, but it just adds a little bit for balance. Our surgeon who used this, and it wasn't just here at Mayo, it was used in the Seattle VA quite a bit in previous years, actually retired. So I don't get to see this intervention. Our current surgeons aren't comfortable with people putting a lot of weight on a pylon, but it actually was pretty successful at times. I've had one patient that we did this for. He was somebody who was admitted to the hospital. He needed an amputation, but he had a flight of stairs he had to get in to be able to go home. Otherwise, he was going to be in real dire straits. So we did fit him with one of these just to get him up the stairs. He actually did very, very well. So we see people in the hospital, like I said, as a PM&R doc. We also get PT and OT to see them. I really try to break things down for the patients to talk about kind of two different phases of rehab after lower limb amputation. Phase one is getting mobile, getting home safely, and protecting the limb, not falling on the limb, not injuring it, and keeping that limb elevated to make sure it heals well and doesn't have significant edema. Phase two is when we're getting you back in, we're fitting you with a prosthesis, and we're really getting your mobility back. Usually it takes about 6 to 8 weeks to heal the limb. It needs to be fully healed, no scabs, no open wounds, and no swelling. We got to get compression on that limb to get the rest of the swelling out before we can cast them for a prosthesis. So that's kind of the goal acutely and the goal long term. And I think it helps for the patient to kind of have a little bit of hope out there. It's like, okay, if I get to that 2 month, I get healed, get in with a therapy gym, and we can really start getting my function back. We've got a protocol here. We're very lucky. So I've got clinic right down the hall, just around the corner from my office. But then just down next to it, I've got our therapy gym where we've actually got 3 different therapists who do gait training. And we've developed protocols even before I started working here. So for a below knee or transtibial, we do 1 week of twice a day therapy, and we get a patient fully trained with their prosthesis in that week. For transfemoral or above knee or hemipelvectomy, hip dysartic, we'll do 2 weeks of twice a day therapy. So it's a really intense protocol. Not everybody can handle the intensity, so sometimes we modify the protocol for folks that aren't going to be able to do 2 hours of therapy every day for 2 weeks. But it's a really nice protocol where we can get people trained quickly, and the prosthetists come to those visits with the patient, and our physician team comes into the gait gym. So all 3 members are right there in the therapy gym with the patient. Those are super fun visits to go to because very often the patient's doing very well and very excited about how much progress they've had. So you kind of get to share that. And I've gotten to be there when they were first getting news, when they were going through it in the hospital. So kind of having that relationship and ongoing presence is pretty awesome. That's why I love what I do. It is important to talk about that loss, talk about the grieving that people go through. Peer visitors are really important. Access to therapists, psychologists, psychiatrists. When we bring people to inpatient rehab, we have a rehab psychologist there. I wish I had a rehab psychologist in my back pocket that just went everywhere I go, but I don't. So sometimes I have to put that hat on myself a little bit. I'm not as good as they are, but I do my best. But that's definitely an important piece that we need to think about. Here is a little intraoperative splint that we put on. A big thing, this is a below knee or transtibial. A big thing is keeping that knee straight. We do not want to develop a contracture. So we really try to keep the knee elevated keep the knee straight, fully extended while they're healing. Then this is that dressing that I showed you where we can attach a pylon and a foot here. So you put some lamb's wool to protect the incision and over the bony prominences, and then a plaster cast, and then can add a pylon. Like I said, I've only gotten to do this on one. Well, actually, during residency, I had a different patient at VA where we did that. So it's a pretty cool procedure. Then, so you do that. They come back to the cast room in about 10 days, take it down, look at the incision, make a new one. And then somewhere around the 4-week time, we would move to a rigid removable dressing. So this is a plaster cast. So we've got a shrinker and prosthetic socks, and then this kind of removable dressing that goes on the limb. So now we're really accelerating in the compression phase, get the rest of that edema out of that limb so it'll be ready for casting. So they can add these white socks under this kind of rigid removable dressing to really accentuate that compression and get the rest of the swelling out. And then once they're healed, we get folks a shrinker sock, which is just a compression sock. They've got different sizes for different limbs, and you really use this anytime you're not in a prosthesis, because again, volume is hugely important. You're making a cast of the limb and making a socket. That limb needs to stay the same size. If you've got fluctuations in swelling of that limb, you're going to have a lot of problems in fitting a prosthesis. So we talked about positioning. Here's a little picture here. So elevation is certainly important, but the problem if you stick a pillow under the knee, if you do that for weeks and weeks, your knee is going to get flexed and get stuck in a contracture. So I just like to lay the leg flat in bed with the knee extended. And then the other thing is the hip abduction. It can actually get an abduction contracture, especially if you're at a transfemoral level. So lying in bed with the leg straight in front. And then I can't tell you how many times I come in, all right, we're ready to fit you, ready to cash you for a prosthesis. Maybe they're wearing the shrinker, but they're sitting in a wheelchair with the knee dependent. And all that swelling's down in the bottom, and it's really limiting how good of a cast we can get. So we like to keep that knee straight and limb elevated. So these seem like super basic things, but they are incredibly important. This is one thing I'll show patients sometimes. We had a patient, he needed a transtibial amputation. He was elevating, he was doing all the things. 6 weeks, the incision was looking awesome. This is in with the surgeon. It's like, this is great. Got the rest of the sutures out. He was so excited. He was almost healed. You can tell it's not quite healed. There is still a little scabbing along this incision. So then the next 3, 4 weeks, he spends out in his garden, his limb dependent, sitting in his wheelchair, and he shows up at the amputee clinic and his leg looked like this. So beautiful incision. You're like, this is practically healed, right? Well, you hang dependent for a month and it ended up dehiscing, and the patient actually needed a revision surgery because he got so excited and then just hung his leg down, and all that swelling, all that edema really, unfortunately, caused the incision not to heal. So these things seem incredibly basic, but they're so, so important for patients to do well. This is the timeline. And again, I've kind of focused on transtibial just to keep it simple here. So we have the surgery, we can put that dressing on, we can come to the cast room within a couple days. They'll put a dressing on at that point. Then we'll do a cast change. Then they follow up again. This is kind of at that 4 week. At this point, they go with the protector, which is that rigid removable. Then they come in the amputee clinic. We prescribe the prosthesis. They get cast. And then they start physical therapy the next week. And then they kind of work through that week and get fully trained with the prosthesis. So that's kind of our initial timeline and how we get people through to their gait training. The socket. So again, you're creating this socket. Let me come show you a socket. There we go. So this is a check socket here, and it is so you get how it goes is you get a cast of the residual limb. Then from there you make the socket that is custom molded to their limb. When they're doing that initial week of training that I've been telling you all about, a lot of times they're in the check socket so that the prosthetist can come. If there's an area of pain or irritation or increased pressure, they can actually heat this check socket up and change the shape. The other thing is if they start walking on their limb and they get more of the swelling out, they can add pads to the check socket so it's not a finished deal. Then they get to the end of the training, the limb is relatively stable, we feel good about it. That's when they laminate. So this dark socket here is made of this carbon fiber material, and then you pour acrylic laminate on it to kind of solidify and let it dry, and it creates this very strong, very hard, and just a little bit flexible material for the laminated socket. And then finally, this is a definitive prosthesis. Now this one has a cosmetic cover over it. It used to be we would do cosmetic covers for just about everybody, and that was just kind of standard of care. At this point, it's more often than not that we leave a lot of the componentry exposed, and people will have designs put on their sockets. So you can bring in essentially any t-shirt design, or the prosthetists have fabrics that they can laminate into the socket. So you can really totally customize the socket portion and really make it very unique to the individual. So that's kind of an interesting trend in how things have kind of changed in the amputee and prosthetics world, where it's just kind of become more visible, and kind of embracing that look has been, in my opinion, kind of a positive change. Let's see here if there were a couple other things. We kind of talked about the follow-up. We talked about the timeline. Yeah. And then we follow, just so you got a snapshot again of what I'm doing. I'll get to see the patient in the gait gym. All right, you're doing well. And then the next follow-up is usually at 3 months after that. And this past year, we've actually developed an advanced gait training protocol. So, okay, you know how to use the prosthesis. You can take it on, put it on, take it off, kind of do some of the basics. Well, you're going to walk in it for 3 months. You're going to run into all kinds of new challenges that you want to kind of expand your repertoire and expand your ability to walk. So, something we kind of as a team thought of is an advanced gait training protocol, which is 2 visits for just 2 days. So four visits with physical therapy at that 3 month timeline, and really kind of, okay, you've been using a walker. Well, let's try downsizing to a cane. Let's see if you even need a gait aid right now. And just really progressing patients. So that's been a lot of fun to kind of add that in. Then we do a 6 month after that, and then we just do yearly visits, or more often if folks are having difficulty. So as long as people come see us here in good old Rochester, southern Minnesota, we'll keep following folks for life, which is another aspect that I really enjoy about doing amputee rehab. So I'm giving you some basics, and I'm selling my specialty at the same time, in case you couldn't tell. Um, it does take more energy to use a prosthesis. So traumatic versus dysvascular. Dysvascular take a higher energy hit. So they've kind of gotten people on treadmills, kind of measured their energy expenditure, and found 25 to 40% for below knee or transtibial. You get to above knee, boy, it's a big jump. I've seen 50 to 60% more energy for the transfemoral traumatic population. For the dysvascular transfemoral, so that's folks with diabetes, folks with peripheral arterial disease, over 100%. They're doubling their energy usage walking with a transfemoral prosthesis. So it is a huge jump up functionally. Using an above knee or a transfemoral prosthesis, the gait mechanics are quite a bit more challenging, and the energy usage is quite a bit more. So it really does make a huge difference if a patient gets a below knee versus above knee. And so that's why, if at all possible, we try to keep folks at a below knee, even if it's a really short below knee, just distal to the tuberosity where the patellar tendon inserts. I'd still rather keep that knee if at all possible. So, who gets a prosthesis? So that kind of feeds into, if it's transtibial, even if the only goal is transferring, a transtibial prosthesis helps with that. Transfemoral, you've lost the knee. And so now when you're standing, you're using your sound knee. You're not typically using the prosthetic knee to stand up. It really doesn't have any force that goes through it to pick you up. So that's a big difference between the two. So I really like, if someone's going to be fit with the transfemoral, I like to have them stand up and be able to ambulate with a walker. Ideally, if they can go 100 feet, that really tells me a lot about their functional capacity. And when you're riding a lower limb prosthesis, we always have to have the K levels. So when you're in PM&R residency, you'll get these beat into your brain because you know you're going to get a bunch of SAE questions on them. These are functional classifications that Medicare came up with, and then we all have to follow the rules, is how that works. A K0 means that someone is non-ambulatory and has no use for a prosthesis. So if you write someone as a K0 and then you write a prosthetic prescription, no insurance company is going to pay for that. A K1, and I apologize, it's probably smaller writing, but a K1 means that they can at least stand and transfer, if not ambulate in the home short distances. A K2 means you can walk outside the home just short distances. K3 is called an unlimited community ambulator. So they're ones that can walk blocks, if not miles at a time. K4 means they can run and jump. K3 is the big one. Because that's the one where you get the advanced prosthetic feet that are carbon fiber and kind of have that extra spring. That is also the one where you get the microprocessor knees. And so saying that someone has the potential to ambulate unlimited community distances is a really big deal. There are some functional tests where you can kind of gauge that ability. So if there's a question of what their K status or K level is going to be, I can get them in with our physical therapist and they can do some tests. One of them is called the AMP Pro, so amputee with a prosthesis. Another one's called the AMP No Pro, so it's an assessment even before they get a prosthesis to try to estimate what their functional level is going to be. So those are kind of things that we always have to talk about for lower limb amputees. And let's see, I'm going to skim through things here just for time's sake. A SIME is amputation at the ankle. So you end up with a pretty bulbous contour, which then translates to cosmetically maybe not as appealing socket. You're also very limited in the kind of foot. So this is a carbon fiber foot, but it's extremely low profile. And if you can imagine, there's just not very much room for that to kind of rebound and have some energy return. Transtibial, we talked about. Ideally, at least 10 to 12 centimeters of the bony length. Some of our surgeons go a little bit longer. The big thing is having a nice flap, posterior flap with a gastroc to give you a nice soft tissue envelope. This is that prosthesis I was talking about. So here's that laminated socket. So this is a finished socket. Here's a little mini pylon. You've got adjustability with these little screws, and here's the prosthetic foot. So you got a carbon fiber foot here. So this is likely a K3 level foot. And then you've got a foot shell that goes over that. And then you wear a sock over that and you just wear regular shoes. I had one patient, and after amputation, their significant other like cleaned out their closet of all their whatever side it was, right or left sided shoes. They only had shoe for one of the feet, and then they come in to be fit with the prosthesis, and we had to get them to buy some more shoes because you still need a regular shoe for that prosthetic foot. And then we can do a deep dive. I'm trying to keep things not too deep, but essentially how the prosthesis is attached to the limb is called the suspension. And we use these things called silicone liners a lot of times. So this one is a liner with a pin, and that pin will lock into the socket. And so that's kind of how it comes on. So the outside of this is fabric, but the inside is silicone. So it's nice and tacky. You turn the liner inside out and you just roll it on the limb. And then, so it's kind of like another layer of skin almost. And then that locks into the socket. There are other ways to attach to a socket. Again, I'm going to not do a deep dive on that, but just know there are other ways. Prosthetic socks are important. So when people start using a prosthesis, those soft tissues will atrophy. And if the patient is really active, it'll actually atrophy faster. So here they add socks over the liner. So you got the liner, then if the limb is shrunk some, that socket's not going to fit well anymore, right? So now you've got to put that sock on to take up that missing volume. At some point, and we measure this in ply. So we're always doing math in the amputee clinic. So you'll have a 5-ply sock, and then I added a 3-ply, and then I did a 1-ply, and then I took all those away, and then I went to 5 plies. So you're always like adding up. It's like, okay. Basically what you're doing over time is watching that residual limb volume shrink and atrophy, which is a normal process. And at some point, their limb's going to shrink so much that the socket doesn't fit anymore. And there's nothing else you can do. And then you have to prescribe a new socket. So that's the reason why we have more follow-ups early on in that first year after amputation, because we know that limb's going to change a lot. We need to keep a close look on the limb and make sure they're following everything so they don't get another problem or ulcer. And then B, they're going to need a replacement socket. A lot of times in that first year, they'll need a new socket if they're pretty active. The prosthetist also can do a lot of alignment changes with those little bolts that you were seeing on the socket. So that's pretty fun. You can do I'm not, again not going to go into too much detail, but if you're seeing gait deviations, a lot of times the prosthetist can literally take out their Allen wrench, number 4 Allen wrench, and like adjust and align and change things and fix deviations in real time. It's pretty fun to observe gait that way. Transfemoral, I was just going to say a couple things on above knee. Early on, years and years ago, they would have a problem with the femur. So here's the femur, head of the femur should be up here. And the femur would AB duct because the AD ductors are often attached. A lot of them are attached distally. Think about where that adductor magnus attaches. And so you lose the adduction, and so the abductors kind of overcome it. And so one of the surgical interventions was to do adductor magnus myodesis, where it gets wrapped around the femur and attached. And so by doing that myodesis, we then allow the femur to stay with anatomic alignment in the socket. And then here's an x-ray after someone had that adductor myodesis. You can see the femur um, on the left, our left anyway, is matching the femur on the right in alignment. And then here's a transfemoral prosthesis. So again, you've got a socket that's custom molded to the residual limb. Now we got to have a knee. This is a microprocessor knee, the Kenevo actually. And so how microprocessors work is that they'll have different componentry, often a hydraulic cylinder. And so the hydraulic cylinder is a dampening effect on the movement of the knee. So essentially controlling the speed of the knee and how much resistance is put through the knee when it flexes and extends. There are then multiple sensors in the microprocessor knee that will tell the computer where the weight is distributed. Some microprocessors will have a gyroscope so they understand the movement and the angle of the prosthesis, and it's feeding all of this information and then adjusting how much resistance goes through the hydraulic cylinder. So if you're walking down a slope, you want this knee to be slower, kind of replace the effect of the quadriceps, slow down that knee flexion to be able to ride that hydraulic walking down the hill. If you stumble and the knee flexes and you kind of land on the toe, what you don't want is the knee collapsing under you and you going down like a sack of potatoes. So if the knee is flexed and pressure's really on the toe, the computer chip knows to slow those hydraulics down, give you that little second to kind of catch yourself with stumble recovery. So the microprocessor came out in the early 2000s, complete game changer for the transfemoral. The tough thing is I have to say when I prescribe this that someone has the potential to be an unlimited community ambulator. Well, I might have somebody that I may not be able to say that, but could still get out, get outside, maybe make it around the block, walk in the home. They would 100% benefit with this device, and I can't prescribe it because of these Medicare rules. So trying to change things, but change is hard sometimes. This is a pretty sweet sport knee called the Moto knee. There's multiple options. This is not the only one here. It's pretty terrible for walking in, but it has this basically like a Fox shock built in. And what it does is it resists knee flexion. So the whole idea with this, it's going to be terrible for walking. It's going to clunk around. It's super heavy, but you can stand on this knee. So you'd attach the socket up here. You would stand and it would put resistance through the knee so that you could ski or snowboard or ride an ATV, ride a bicycle, anything where you're standing with your knee flexed and you really want to use your quadriceps to kind of stabilize and not just put all your weight on the other leg. That's what these knees are kind of designed for. So the guy who designed this lost his leg in a snowmobile accident. He's like still healing from his amputation and goes in his garage and starts like building these so he can get back and snowmobile, ATV, all the things. So the guy's absolute maniac, but he's pretty awesome. His name's Monster Mike. So you can look up the Moto knee if you want to check that out. He's got some cool videos. All right. And then, oh yeah, this is just a quick take on a hip disarticulation prosthesis. So you can tell these sockets have to come way up and really hold the pelvis. And we've got to replace the hip joint, the knee joint, and the foot. So it is a massive, massive prosthesis. Takes a ton of energy to use. Another amputation that we do here, and it's not unique to Mayo by any means, is something called rotation plasty. The reason for this is often a distal femur or proximal tibia sarcoma. So we've got a tumor that needs to be removed to save the patient's life, but their distal tissues are completely intact. So their ankle and foot have no pathology. And so what the surgeons do is they remove the tumor, they dissect out the neurovascular bundle, and then they rotate the tibia 180 degrees and then use a pin to connect it to the femur. And now it's a weight bearing. So it's got to heal. It takes a little longer to heal, usually 3 months, but then we can fit them with a prosthesis. Commonly, this is done for children because if you do an above knee amputation on someone who's not finished growing, it's going to end up a very short transfemoral residual limb, which is going to be really hard to fit with a prosthesis. So what you're doing is essentially not giving someone a new knee. And so now they can really use that activation, extension, and flexion at the ankle, which kind of becomes their new knee. So it's a pretty cool concept. And these patients do incredibly well. They're running, they're jumping, they're really happy with their outcome. So I've done a terrible job of plotting my time and not giving much time to upper limb amputation. That's completely my fault. But I'll give you just a few high points on upper limb stuff. So far less common than lower limb amputation. So we estimate somewhere around just in the thousands with major upper limb loss or difference, as opposed to, you remember, for lower limb, it was, getting close to 2+ million. Usually this is due to trauma. So 90% of our upper limbs amputations are due to trauma. And so, typically a younger and more healthy patient population here. There is congenital limb difference, but only 4 per 10,000 babies. Often we don't know why. Levels of amputation here. So anything from a partial hand, transradial or below elbow, transhumeral or above elbow, shoulder dysartic, or even a 4/4 amputation, a fit with a prosthesis. And by I mean the team. I wrote the script, and then the prosthetist had to do all the work. But they did a marvelous, marvelous job. So we need immediate post-operative. We need to get the wound healed. We need to maintain range of motion within what the surgeons allow us to do. And once they're healed, we want to really move quickly to fit them with a prosthesis. There's this idea of this golden window of 3 months that if we don't get them using a prosthesis in 3 months, they may not incorporate a prosthesis. I don't know that we have strong evidence of that, but it certainly is a fact that upper limb prosthetics are more often what we call abandoned, which has a little bit of a negative connotation, but more often prescribed and not really used compared to lower limb. And one of the theories on that is just the complexity of the human hand and what we use our hands for. If you think about how the hands move, the grasp, the grip, the sensory feedback at our fingertips, we cannot currently replicate that with a prosthetic hand. So if someone says they just want their hand back, they're going to be extremely disappointed in what we have available. So I try to get folks to think about it like a tool. So some things you may just want to use your residual limb for, some things you may want to use a prosthesis for. It's really finding out your goals and fitting to that. So the overall broad categories are passive, body-powered, and externally powered prostheses. So there's passive prosthesis. This is one that's holding onto a bike handle, and this thumb will kind of break away if need be. The functional silicone hands are unbelievable. There's actually artists, so they're made of silicone. There's artists that will turn them inside out and paint them and then reflect them back, and they just look unbelievably natural. A lot of times they're using the contralateral hand as kind of the copying point for that. Here's another passive prosthesis. This one's used to throw a ball, obviously attached as a terminal device. There's body powered, where we use the movement of the body attached to a cable system to then kind of control the terminal device. So here's a figure eight harness here. And it's called figure eight. If you just turn your head sideways, that's the way I think of it. It's like, okay, here's the top loop of the eight, here's the bottom loop of the eight. So that's the eight idea. This is for a transradial amputee prosthesis. There's a cable attached here, and that cable runs through a channel and then comes to the terminal device. And you either flex at the shoulder, so kind of reaching forward, or by scapular abduction here. So both kind of shoulder blades moving over. All you're doing is putting tension through the harness, which then puts tension through the cable, which then controls the terminal device. And you can have voluntary opening or voluntary closing device. And then finally, what everybody, and there's hooks. Hooks can actually be highly, highly functional. They give you a great, they don't take up a huge amount of space, so they don't block your view. So that's a big thing with upper limb prosthetics. You're really using your vision to replace a lot of that sensory feedback of the sound hand. And then finally, externally powered or myoelectric. So you have these little sensors built into the socket that pick up myoelectric. So basically, they pick up movement from your muscle of the residual limb, and then they translate that to movement in the prosthesis with powered fingers and a powered hand. So here is one of the myoelectric hands, the iLimb, and it is multi-articulating. You can grab this thumb and pivot over, so you can do both a lateral pinch as well as a tripod and power grip, so multiple grip positions. This here you can't see as well, but instead of a two sensor array, this has sensors that go completely around the circumference of the residual limb. It's called pattern recognition. And so here, instead of just flexing if flexing the wrist or extending the wrist idea, if you're transradial, you can make more natural movements, and it picks up the entire pattern of that movement. And then as long as you do the same pattern of muscle movement repeatedly, you can kind of control the different grips. So that's kind of taking it to the next level. So again, I apologize. I shortchanged the upper limb prosthetics, but I'll take a pause because I've been rambling for a long time and see if we got any questions. I'll get out of this share screen thing here.
Thank you so much, Dr. Smith. That was wonderful. Yeah, there's a few questions that were sent in beforehand, and then a couple that were during the talk. So, and oh, there it goes. Okay. So one person asked, what is the earliest timeline for shrinker sock for BKA, AKA?
Yeah. So good question. Usually we will, if we use really light compression, I've had some patients that we fit within a week of amputation with just real light compression and use something called a donning tube to do it. The thing I worry about with a shrinker sock on a residual limb is if you get a really strong 30 to 40 millimeter mercury shrinker sock, pulling that on over the incision may cause trauma to the incision. So I would start with light compression, and there's a donning tube, which is basically a big plastic cylinder that you stretch the compression sock over, and then you kind of you basically push the leg into the donning tube, and it just pops it right on without having any traction over the limb. Just imagine a huge PVC pipe that's like bigger diameter than the leg, and then pulling the sock over it, and then you just like pop it on. It's a pretty sweet trick. If we're doing those rigid dressings that we used to always do with one of our former surgeons, then we would not typically put the shrinker sock on until about 4 weeks post-op when the suture's removed. But that's because the residual limb was protected in that plaster cast.
Perfect. Thank you. And another question was, can you comment on medication dose adjustment given change in their vascular volume?
We don't usually make medication dose adjustments. I have not seen that typically. You are correct. You are losing a portion of your body, but I don't think I've seen adjustments based on that. At least I've never seen it.
Okay, perfect. And then let's see here. I have three other ones that were sent in. So we'll see if we have time for them here. So the first question is, given the rapid advancements in prosthetic technology, how do you approach integrating these new developments into your rehabilitation plans for amputees?
Good question. For some of it's trial and error. Some of it is staying up with the latest kind of research studies. The problem with a lot of research studies is they're pretty small number studies a lot of times. Um, a lot of it's the multidisciplinary discussion with our physical therapists, with our prosthetists. So I really trust my prosthetist judgment that I'm working with. And the prosthetists really build a relationship with their patients as well. And so picking out the right componentry for the patient is absolutely key. One thing we didn't get to is a hydraulic foot and ankle that I really, really like for active folks that are going to be walking on uneven terrain a lot because it's got a lot more range of motion. And so one thing I've been doing recently is prescribing those earlier, is sometimes even for their first prosthesis. So that's kind of something I've noticed changing. So a lot of it happens as you get more and more familiar with the technology, as you get more patients fit with that technology, you see how they're doing. I'm always getting feedback from my patients on what's working, what's not. So it's a constant process. It is research. A ton of it is just clinical experience and listening to your patients, though.
Hi,
Go
Doctor.
for it.
I had a quick question. Thank you for the presentation. And I kind of have two questions that go hand in hand. One was that with the advancement of like 3D printing and also other technological advances, is there an effort to kind of mimic uh, the prosthetic to have like vibrational sensing, like positional sensing, and kind of mimic the different nerve innervations that go on in a regular like human leg or arm. And the other question that kind of goes along with that is, in addition to that, are there any measurements that are taken or strength testing that's done before someone actually undergoes the operation for amputation? Like if it's a lower leg amputation, do they measure the size and I guess diameter and strength of the calf muscles or lower limb muscles to kind of get a better fit for a person after they undergo an amputation?
Yeah, good questions. For 3D printing, we are finding new ways to use that, in particular with upper limb prosthetics, since you don't have nearly the weight load. Um, with that, you're not putting your entire body weight through the prosthesis. I've actually got a patient in the hospital right now who I just prescribed partial hand prosthesis with 3D printed digits. So we'll use a silicone um, kind of inner liner and then attach the 3D printed digits. It's going to start with just basic grasp for this particular patient, but some of the partial finger prosthetics that are out there take many weeks to measure, order, fit. As opposed to 3D printing, I'm hopeful we'll be able to get this for him next week. So there's a great turnaround with 3D printing. As far as sensory feedback, the problem with sensory feedback, like you're talking about the vibration or the pressure or what have you, it's really sensory substitution there, right? So, okay, my prosthetic finger touches, makes contact. Now something higher up on my arm is vibrating. Oh, okay, that's telling me that my prosthetic finger made this contact, right? So now your mind is having to make yet one more leap on, oh, I feel this, but this is actually what that means. So it can be quite a cognitive load, I think, for some of the sensory feedback pieces. There are experimental prostheses where they are using implanted electrodes on peripheral nerves for both controlling a prosthesis as well as the sensory feedback. And the advantage there is it is much closer to kind of, if you kind of tingle that nerve, let's say you're tingling the ulnar nerve in the
Mm-hmm.
homunculus, it's going to be associated with that portion of your hand. So less, it'll still be maybe a little bit different feeling, but it's at least a closer jump there. So I'm kind of excited about that, but it's an implanted device. Those are very much on the experimental side. I do not have any prosthetics that I can currently prescribe with implanted electrodes. Um, Finally, as far as pre-amputation measuring, we don't typically do specific, if I'm concerned about someone having a neuropathy or being extremely debilitated, I mean, we'll do things like manual muscle testing. We're not doing exact measurements of knee extension on a machine and kind of find out those numbers. We don't typically do that. To me, a lot of times the history and what someone is up to prior to amputation tells a huge amount of what they're going to be doing post amputation. When you kind of keep in mind that kind of, 30% increased energy for a transtibial kind of ballpark. So that's typically what we do in clinical practice. There's a lot of cool things you can do in research, but then you've got to figure out a way to make that work in the clinical world.
Yeah. Okay. Thank you so much. I appreciate it.
Great questions.
Hervey and then Michael, and then we can wrap up.
Awesome. Thank you so much for your presentation today. I'm a first year at TCOM in Fort Worth. And my question for you is, have you had any patients who maybe were athletes prior and are interested in getting back into the athletic world afterwards, like per se running, or something I'm particularly interested in is like the Paralympics? And so how do you kind of tailor your treatment to someone who is looking to kind of do a high impact sport again with that increased load, especially maybe like shockwave and runners?
Yeah, absolutely. We have gotten to take some patients over to so we've got our regular therapy gym here. We've got our sports center that's just like a block away that has an indoor turf field. And so our therapist has done some gait training. I think we've taken 3 folks over there so far to do gait training. One of our patients was a marathon runner and really was super important to her to get back to running. And so the tough thing was timing on when is that limb going to be able to kind of take that kind of increased pressure and dynamic movement. And we know those first 6 months after surgery, that limb is going to shrink a lot. And so can we get a stable socket where it's going to be that we're not chasing that volume too awful much? But we were pretty successful with that. It was a lot of fun. I kind of put it on my to do and kind of showed up and watched this patient run. It was emotional. It was really cool. And we also got to trial like I think 3 different running feet. And so she kind of got to try the different running blades to see like which one they really liked the best. So that was fun to get that feedback too, to have her do that. So yeah, we get to do that for some patients. It's a ton of fun to get somebody running in.
Thank you so much.
Yeah, absolutely.
I just had one question. My name is Michael. I'm one of the following in the footsteps of Davis at LUCOM. I just had a quick question about the more like the affordability side of prostheses, and because I worked at a pain clinic before med school, and there were a couple of sad stories actually of some patients who couldn't afford like a new prosthesis, or a prosthesis in general, and then wound up either one needing like more pain medication because of it, or even there's one particularly sad story where a lady wound up needing her better limb that she didn't have amputated. She wound up breaking it a bunch of times and actually wanting it to be amputated as well. And so I guess I would wonder I mean, I do not know personally from their experiences, but like, what would you say are the resources that are available to help more specifically like lower limb amputees who are struggling to afford new stuff like that?
Absolutely. Yeah, no, prosthetic limbs are incredibly expensive. For example, if you're paying out of pocket for a socket, just the socket alone with the liner, I mean, you're looking at literally like $8,000 to $10,000 just for that alone. And then you get the foot microprocessor knees can go 50 plus. So yeah, I mean, even if someone's doing pretty well, they're not going to have that kind of resource. So really ensuring that folks have access to health insurance, and then utilizing that to get insurance to pay for these devices. So I get into insurance battles all the time. It's the least favorite part of my job, and can be incredibly frustrating. The other thing is, right, sometimes patients don't have insurance at all. And so getting them those resources to have that is absolutely essential. It is tougher to get activity specific prostheses paid for by insurance. They usually need like a medical necessity. So for like running blades and things like that, sometimes those are unfortunately out of pocket. The Amputee Coalition is a really nice nonprofit, and they've actually got a resource page. Yeah, so it's Amputee Coalition. If you just Google that, you'll find amputeecoalition.org. And they've got a resource page to help pay for prosthetics. So it's a list of nonprofit organizations that are available. A lot of times, prosthetic companies will have some funds that are limited. I've even known prosthetic companies to have like used componentry, so they can't really charge for it. Maybe it's a component that somebody donated, um, and it's not going to be ideal, but it'll kind of get through in a pinch. So sometimes that'll kind of help in between like getting insurance, but it's absolutely essential for folks to have insurance to be able to pay for these very, very expensive devices.
Yeah,
But
yeah.
yeah, check
Thank you
out
so
Amputee Coalition. It's super, super nice
much.
nonprofit.
Yeah, definitely. Yeah, I'm actually gonna be working there this summer, so I can even tell the patients there about it because there's
Perfect.
way more than a couple that really struggle with not being able to afford prostheses. There's one person that's been using the same uh lower limb prosthesis since like 1970 or something, and it like hasn't
Whoa. Oh my goodness.
it's
Oh
like
my goodness.
really sad, but yeah,
The
yeah,
other thing to think about is if someone is a veteran, the VA has a lot of really nice resources. So if someone's struggling, I always try to remember to ask if they're a veteran or not, because sometimes they just haven't tapped into that. And VA paperwork sometimes takes a while, but there are good resources to help folks. So
wonderful. Thank you so much. Thank you so much.
absolutely.
And Dr. Smither, I guess just on that note with the Amputee Coalition, as we just end our time, are there any resources you'd recommend for us medical students as we go through our training and residency, hopefully in physiatry, that you'd recommend specifically for amputee rehabilitation?
Yeah, I mean, read as you go along. I think a nice one for you all, oh goodness, is this little fella. It's not big, but the Pocketpedia. I bet everybody's got a copy. Its chapter on amputee prosthetics is actually not bad. They get into a lot. So it's amazing what you can type when you're doing like tiny font. So Pocketpedia is pretty nice when you're going through rotations as a med student, because it's like you can pop out and just like read a chapter on something and get a lot of high yield there. And then ultimately, when you are in residency, when you are studying for boards, I'm a big Cucurullo fan. I've got it right here on my shelf. It's an absolute Bible. Some people don't like reading 800 pages, which I totally get. I've heard a lot of good things about PMR Recap from multiple residents. So that's a nice online resource. And they've got a lot of videos. So if you learn better watching a video, PMR Recap's a good way to go.
All right. Well, thank you so much for your time tonight, and that was helpful for so many of us. So we just really appreciate it. So I'm sure everyone's clapping with their muted mics on. But thank you so much, Dr. Smither. We just really appreciate it, and hope you guys have a wonderful night. Thank you for coming, and we'll see you all soon. Thank you so much.
Awesome. Y'all have a good night.
Thanks, Dr. Smither.
You as well. You as well.
Thank you.